Amanda, thank you so much for joining us on ODONTOJAM.
Thank you. I'm really, really pleased to be here.
We're really glad you decided to come on the show. Really looking forward to discussing all things oral medicine. And probably a lot of people listening have actually come across a lot of your content as well. I know it's definitely been useful to myself and a lot of other colleagues in my year level. But for those who maybe haven't come across your content yet, and after this, I'm sure they'll be having a look. Would you be able to give us a little bit of a background into your journey into dentistry, and then eventually how you found your calling to oral medicine?
Yeah, so I did my dentistry actually at the University of Melbourne, which is where you are, I believe.
Yep.
So when I was in high school, I had a really, really close friend who was a few years older than me, and she was doing dentistry. At that stage, I was thinking that maybe I would like to do law, a typical year 11, year 12, didn't quite know what I wanted.
Yep.
And then through her, I found out about dentistry and I thought it was a pretty cool career. So I signed up and I did dentistry. At that stage, it was an undergraduate program.
Yes.
It's actually quite funny. People who know me will know that this is true. When I was going through dental school, I was like, who would ever specialize? This is studying is not good. Like, why would you limit yourself to one thing for the rest of your career? So I graduated and I started working. And after a few years, I realized that I wanted to know more about one topic. I did some further study through the Royal Australasian College of Dental Surgeons.
Yes.
And then I narrowed down the things that I thought were interesting, or the things that I liked, which was oral medicine, obviously, and also pediatric dentistry was a close second. I did some work experience in the area, and then I fell in love with oral medicine and kind of never really looked back after that.
Yep. Oh, that's fantastic. So was there any other area of general dentistry that sort of had your interest, or was it just kind of oral medicine in the end?
Well, when I was going through dental school, I liked endo, which now in hindsight, I can't see how that was ever possible.
Yeah, fair enough.
Yeah, so I guess when I was in dental school, I didn't really know what I wanted. I knew I liked seeing kids, so pediatric dentistry was something that I did consider very seriously. But after a while, I think it became clear that oral medicine really was the right fit for me because I found it really interesting and I would spend a lot of time reading up on it. I think the thing with oral medicine, though, is that when people think of oral medicine, they think about all their lectures at university and all the rote learning and things like they had to do. Oral medicine is actually a lot more interesting than that. So I think if one of the things that I've been trying to do is to try and make my content accessible, try to make oral medicine accessible and interesting. So it's not just, histology slides, like it all falls into a really pretty picture and every patient is really different and quite interesting.
Yeah. Oh, there you go. Well, yeah, you're definitely right. The way that it's typically portrayed is just a lot of memorization, a lot of histology slides, lots of textbooks. I don't know if it was the same when you were going through. A lot of the slides are generally very bland and so not as visually engaging as I think it could have been. But it seems to be running a trend.
Yes, because I think with oral medicine, when you are studying for exams, at the undergraduate or at the dental school level, a lot of it is pure memory work. And I think as you start to delve deeper into it, the clinical and the histopathological and the psychosocial factors, it all comes together and then it makes sense and it makes it more interesting and easy to learn. So, so I think that's where I ended up.
Well, we're going to dive into oral medicine and your daily practice in just a moment, but you've also worked in the Navy in your early years. Is that correct?
Yeah, I did. So I was actually sponsored by the Navy in my final year of dental school. So when I was in the Navy, I worked as a general dentist. So for a few months after you finish dental school, you do officer training. So no dentistry at all. So it's pure military things. And then afterwards, I worked on base for a little bit as a general dentist, which I found was really interesting, actually. I quite enjoyed it. And I still keep in contact with a lot of the friends that I made during that time because, when you have to get up at 5 a.m. and run around and carry ropes and stuff, it's you form a bond with those people.
Yeah, definitely. Would you recommend it for graduates or people in their final year of dentistry as something to pursue? Do you think it's for everyone?
I don't think it's for everyone. I think everyone should look into it because it's very It's very interesting. And the military were very supportive, especially during dental school. I had access to textbooks. The military, the friends that you make during military training will stay with you for life. It's quite interesting. So it's unlike any other career in dentistry that you will have, but it is not for everyone. So one of the things with the military is that you have to be obviously in good health. There are medical conditions that if you have will make it difficult for you to stay on or to be deployed.
Yeah.
And the other thing as well is there has to be some degree of flexibility regarding where you will be posted to. So if you join the military thinking that you'll be able to tell them that you want to stay in Melbourne or Sydney, doesn't always quite work that way. So I think there has to be some flexibility with that. But yeah, no, they're definitely very supportive. The healthcare, the dental care that you receive really is quite top notch.
Yeah. Oh, that sounds great. So what was the total amount of time you were there for again?
So the way that it works is usually the years that you were sponsored for, plus 3, but that does change. So you have a return of service obligation, and I think that will depend on individual circumstances. I can't really remember now, but I think it's the number of years that they sponsor you plus 2 or 3 years on top of that.
Okay. All right. Oh,
yes.
Oh, great. And did you see many oral medicine cases there that kind of caught your eye going through the earlier years there?
I saw a few, but not a lot. There was a lot of temporomandibular joint disorder and bruxism.
Yep.
There were a few mucosal lesions. At the time, there was a oral surgeon that was working on base, and he was a lovely man. So I followed him around a lot and saw all the interesting cases that he did. So there was some oral medicine exposure there. In hindsight now, probably not a whole lot, because what happens during my final year of the military training was that they started to send military personnel out to the private practices of specialists, so you don't see as many on base. Yes. But I definitely saw a lot of endo cases. There was endodontist on base, a prosthodontist on base. And I think the other thing about the military, they're very supportive with CPD, with continual professional development. So if great. You wanted to attend courses and things like that, they would be very good about that.
Oh, okay. Oh, that sounds like a really, really great experience. I mean, you've mentioned now that oral medicine, the taste that we get going through uni is quite different to your day-to-day practice. So in your day-to-day practice that you've seen both in Perth and in Darwin, would you mind just telling us what a typical day looks like for you?
Yeah, I mean, it was my experience that it was quite different, because I think I found oral medicine in dental school quite stressful in terms of just the pure memory work and trying to learn everything. It wasn't until I think I finished and started to look into it more deeply that it all started to come together. I certainly know a lot of students now who love oral medicine, and I couldn't be happier about that.
Yeah, of course.
Yeah. So my day-to-day practice. So in private practice, I see a combination of obviously new patients and consults. They are fairly evenly split between oral facial pain conditions and oral lesions. Okay. So oral lesions would be patients referred in for, red patches, white patches, yes, lumps and bumps, or anything that is unusual that has been found. We do get patients referred in for radiological findings as well. So an OPG has been taken and they found a radiolucency or radio opacity. Yep. Sometimes we get some more unusual cases where it isn't quite an oral condition, but it's something like a facial swelling, a salivary gland disorder, bad breath, oral burning, all of that sort of stuff. Yep. So we get a fair share of those. And then the other big part of my practice is facial pain. So headache, temporomandibular joint disorders, myofascial pain, muscle pain. So anything basically above the head and neck that can be sore, we do see. We do work quite closely as well in multidisciplinary teams. So if I do see a patient, for example, suspected trigeminal neuralgia, there are neurologists, neurosurgeons and stuff that I work in conjunction with if they need more than medical management. And also I do see patients who need a mandibular advancement device. Now, these are typically referred to us from sleep physicians and stuff like that. So if they need help with a oral appliance for sleep, that's something that I do as well. Oh,
right. So that's a very broad range of areas within oral medicine that you deal with. Do you have a favorite out of any of those?
I like them all because I think I'm still fairly early in my career. I haven't quite I find it all very interesting, and I do like it all. I think if there's one aspect that I particularly like, is actually pediatric oral medicine.
Okay.
So I love it. So I love it when the kids come in.
Yeah.
But I think that's a personal thing, because they're I find the conditions quite interesting, and I also like the interaction with the kids.
Yeah. Okay. Oh, that's great. Do you get a lot of pediatric oral medicine come through, or is that more the minority of patients that come through?
It's probably the minority of patients. I mean, we do work hand in hand with quite a few pediatric dentists as well. So obviously there will be a little bit of crossover. I do see quite a few facial pain conditions, temporomandibular joint disorders, and facial pain from kids coming through.
Right.
And a lot of mucoceles and oral lesions. The other things, like the acute things like the viral infections and the recurrent apathy and things like that, we don't see as much, because in the acute setting, they don't, in WA at least, they don't tend to come to oral medicine first.
Yeah. Okay. All right. And when you do get referrals from dentists, what do you think the general dentists are typically missing, or what do you think they struggle with the most when it comes to oral medicine?
Oh, that's a really good question. Like in terms of things, I find that, okay, so this is obviously a skewed sample, because I think that my referrers are not missing a whole lot, because obviously they've seen it and then they've referred it in.
Yeah.
But as a general comment, I think the first thing that I would like to let general dentists know is probably to have a little bit more confidence, because I know sometimes oral medicine can be really confusing, because you see a white patch and you're like, did they bite themselves or is that cancer? Like it's it's very easy to doubt yourself. But in more cases, so I actually form really close relationships with my referrers. They're welcome to call me 24/7, text me 24/7. And a lot of the times they send me something and they're like, is this something? 9 times out of 10, or almost 10 times out of 10, it is something that does require further investigation. So I think maybe having a little bit more confidence, because this makes a big difference in how you communicate with your patient, which I'll come back to. So I think having the confidence to tell the patient that there is something there that they are worried about is something that I can see missed quite often, because the worst case scenario for that is that the patient actually thinks that it's nothing much, and then they don't end up coming in. And it was something to begin with. So what happens with this lack of confidence is that dentists start doubting themselves, and they start doing things like, oh, let's just polish down the teeth, or like, let's just make you a splint and see if your temporomandibular joint goes away. Like, you know what I mean? Like they end up delaying the referral, thinking they're helping out the patients because they're not sure, but sometimes it actually ends up harming the patient instead. So back to my point about what I was saying about having the confidence with the referrals, is that if the referring dentist is not educating the patient properly, or not sharing the gravity of the situation with the patient, what actually ends up happening is that the patient doesn't come to the specialist. So imagine if you're the patient sitting in the chair, and I pull out a bunch of name cards and I give it to you and go, okay, so these are some oral medicine specialists. There's a white patch there. Could be something, could be nothing, but give them a call and make an appointment. Chances are that when the patient leaves the room, they will forget what you've said, or they will not call up. If they do call up, the specialist will then let them know their charges, which is reasonable for a specialist charge. It's not like it's exorbitant or anything. But the patient will be like, oh, is that a couple $100 just to get this white patch looked at? Nah, I think it was fine. The dentist didn't seem that worried. So I think my number one tip is that if you do think that is something that needs to be referred, you have to tell the patient that. My second tip is medical legally, which I don't know if this happens in Melbourne. It happens a little bit in Perth, although I think it's better now. If you give a bunch of name cards to the patient and tell the patient to call the specialist, there's a huge medical legal risk for the dentist, because the patient is your responsibility until they see the specialist. And if you give them the card and they don't call, you don't know that the patient. You don't know if the patient whether the patient has seen the specialist or not, and you can't follow up on it. So ideally, what it works, how we do it here in Perth, in the practice that I work at, is that the referring dentist sends us the referral. They can give a copy to the patient, and then the patient either calls us or we call the patient. If the patient goes, oh no, actually I'm going to cancel my appointment, or I don't want to, or I can't afford it, we write a letter back to the referring dentist. So the referring dentist actually knows that the patient hasn't gone in. Because what happens if the specialist has no idea that the patient has been referred in is that you've got a patient walking around, for example, with a potential SCC, and if it happens and if it grows bigger, like APRA's going to come and ask you, like, why didn't you refer that patient appropriately?
Yeah.
So I think that's like the number one tip, right? So doing appropriate referrals, like always cover yourself. Keep a copy of the referral. Send the referral to the referring practitioner. If they tell you that the patient hasn't come in, call the patient and say, I've referred you to Dr. Amanda about this white patch. I was a bit worried about this white patch, but they've told me that you've cancelled your appointment. Yeah. And then the patient will tell you why they haven't gone. You document that. So that covers you as well. So I think this that's probably one of the biggest tips that I would like to give out, which is that if you're going through the effort of referring the patient, explain to the patient why and keep records.
Yeah. No, definitely very good tip and reminder there. What about, and on that same topic, what about for the patient who you suspect there's a very high chance that it is malignant, there's a malignant lesion, and you're trying to explain that to the patient to an extent, but you kind of don't want to say too much because you don't know for sure yet, even though you think there's a high chance that it is, but it 100% needs to be looked at. And then the patient starts to ask more questions, get worried. That could be, we're not taught how to communicate that in university or even many other courses unless you go to specific ones. Do you have any tips there for those very difficult conversations?
Yes. So I've actually filmed a video with a general dentist in Sydney who's great at communication, because this is a very common scenario. You will get different school of thoughts. So I'll share both with you. When I was a registrar, when I was going through my oral medicine training, I had a patient that wouldn't come in for his results of SCC. We did a biopsy, it came back as malignant. Now, I spent a very long time wondering if I had actually told him how serious I thought it was, if it would be easier to get him back in. And there was a visiting consultant from the UK at the time who's a brilliant man. And his thoughts were that if you think it is serious, you need to let the patient know how serious you think it is. Now, I've also had equally respected colleagues who tell me that sometimes if you're not sure, then maybe you shouldn't say it. So I think it has to be targeted towards the patient. If you think the patient is unlikely to get it looked at because they seem blasé or they don't seem that worried about it, I think you almost have to target the message to them so that they know that you are seriously concerned about it. And if you find that the patient's a highly anxious patient, you still have to give them the same message, but you can frame it differently. So my tip is that so when you first see the patient, you bring them into the chair, you have a chat with them and you talk to them about the screening that you're about to do. You can say that as part of your comprehensive oral examination, I'm going to be doing an oral cancer screening. Now, if you find something, you tell them, look, there's this red patch that's on your palate and it looks a little bit unusual. Let me get my receptionist to call the specialist and see if we can get an appointment for you. That's pretty much all you need to say, because the patient already knows you're doing an oral cancer screening. They know that you found something and they know that they should not sit on it because you're going to help them make the appointment. So there are ways to say it without actually saying oral cancer if you're not sure. And if the patient pushes you and you do think that it is worrying, I think it is a better alternative to tell the patient that you are worried that it's something suspicious than to downplay it too much. Because as humans, right, our natural instinct is like, oh, don't worry about it. It'll be fine. Like, I'm sure it'll be okay. I just want a specialist to have a look at it. But if you downplay it too much, it's actually worse for the patient, because then they might not end up getting it looked at properly. Another tip that I would say is that I think it's really important to form relationships with the specialists that you usually refer to, across any specialist, because in a situation like that, what I would like is that is for my referrers to contact me or contact the practice and say, look, I really think this is urgent. Can we get them a sooner appointment? And we will always try to accommodate. If not the same day, it'll be very soon. So I think if your gut is telling you that something's not right, it's always better to err on the side of caution. And the specialists, all the specialists I know will never throw you under the bus. Like if you thought it was really serious and it came back and say it was a benign growth of some sort, we're not going to go like, oh, look, the dentist shouldn't have referred you in. It was nothing. We would never say that. We'd be like, look, the dentist picked it up. It did look unusual. We've done the biopsy now. And the great news is that it is a benign tumor. So, the cost to the patient is a lot higher if you downplay it too much. And I think as professionals, it is our job to give the message, just framing it differently. So that tip I gave you about mentioning at the start that it's oral cancer screening, then you don't have to reiterate because they know that that's what you're doing and they found something. the other thing as well is that sometimes if they've come in with someone to the room and stuff like that, you can ask like, oh, I see that you've come here today with your partner. Would you like me to get them in so I can tell them about this thing that I found?
Yeah.
And then this is more for like, for example, the blokes that you've got this feeling that they will never follow it up by themselves. And then you just reiterate and say that, look, I found something there. I'm not 100% what it is. It does need to be looked at. So I'm going to try and help you get the appointment with the specialist because I think it should be looked at sooner rather than later. So something like that shows the gravity of the situation without overplaying it or underplaying it.
Yeah. Okay. No, I think that's really good in kind of incorporating it in the general discussion from the start. That's kind of what you were saying, it being part of the exam. Yeah.
Yeah. Or even if you haven't said it, you can say that you found something and it looks unusual and that you would like to get it looked at. Like I think that's perfectly reasonable. And you can draw analogies. I like analogies. So it can be like, you've gone to the GP for a mole check and they found something a little bit funny and they need further investigation. Like most patients will understand that the similarity there.
Yeah. Yeah, no, I think that's a really good way to look at it. And like I totally agree. It's always better to not downplay it, but rather just be very thorough and explain to them clearly what you're seeing. But I guess it is a little bit of an art determining which patients are going to receive which words more favorably than others.
Yes, but then the way that you cover yourself from doing that is that you write the referral and send the referral to the specialist. So you've done the right thing. And then the specialist rooms, like you can put in the referral, like, can you please contact the patient? So the specialist rooms will then call the patient and explain to the patient. So the people that I work with, they're trained to go like, Dr. Liang's referred you to Dr. Amanda because he found this area there. He was a little bit concerned. He's asked us to make the appointment for you. And these are the available dates. So like it's reinforced.
Yeah, that makes complete sense. I think that's
Yeah, there's actually another tip that I would like to share, which is another common scenario which I face, which is that they see dentists see something and they don't know whether it's serious or not. Because I think if it is serious, then it's pretty clear that the patient needs a referral. Is just how you say it. But if you find something and you're like, is that something to worry about or not? The 2-week rule is brilliant because that also helps the patient accept it. So you can go, look, we found a white patch in the area. It could be from rubbing from this sharp tooth next to it. So what I'm going to do is that I'm going to smooth this sharp tooth over and I'm going to bring you back in 2 weeks. Now you must come back in 2 weeks and we'll have a look at the area. If the white patch was because of the sharp tooth, the white patch will go away and then we don't have to worry about it. If it's still there, that means it could be something that that needs further looking into. So then I'll refer you to the specialist because then you've already set that expectation. So if the patient comes to see you again and it's all gone, then all you do is take a photograph and tell the patient that it's all good and tell them that you've got good news for them. And if it is something that is still there, then they already know that that needs to be looked at now. So the 2-week rule is also very, very helpful. The only caveat to that is to make sure that you have the recall systems in place to actually follow up with the 2 weeks.
Yeah, so they don't fall through.
Yeah.
Yeah, no, I think that's good. I'll definitely keep the 2-week rule. 2-week rule in mind. Look, you mentioned you see a lot of TMD come through your practice as well. Now, TMD is an area that's incredibly multifaceted, multifactorial, many different components and different treatment philosophies as well. From your perspective as an oral medicine specialist, what's your take on TMD in general? And do you have any insights into new developments, new ways of thinking about TMD that are kind of coming through the literature?
Yeah, look, it is slightly controversial because, as you say, there are a lot of different practice philosophies, but there is no doubt in my mind whatsoever that when people are treating temporomandibular joint disorders, they have to consider the psychosocial factor of the patient. So you have to treat them via something that's called a biopsychosocial model of management. If you just give them a splint and you never see them again, you have not fixed the patient's TMD. You've actually just charged them for a splint, and that's about it. So I think if you want to treat TMD, you have to be, you will need further training from what is done in the university. You have to be prepared to manage these patients who are chronic pain patients. And the other thing as well is that there's also no doubt in my mind, and no doubt in the literature really, that the old paradigm of occlusal adjustment for TMD is completely debunked and outdated. So people that are still adjusting teeth to treat TMD, doing crowns and rehabs and stuff to treat TMD, the literature is quite clear on that. I think if you want to do occlusal rehab for the patient's prosthetic needs, yeah, sure, definitely. But to treat TMD, that is not accurate. That's been completely debunked by world experts.
Yeah. Okay. Well, then how? I know you mentioned dentists you recommend would need further training. What is the best way? Do you think a general dentist should start out, or what resources would you kind of point them to get the ball rolling in terms of their TMD specific education?
Yes. So there are people that are going to be there are people that are going to disagree with me, but I feel that if you want to manage TMD, that should be the bulk of your practice. I feel very strongly because I see a lot of these chronic pain patients who are really suffering and have really, their quality of life is really bad. So I feel that unless you want to almost restrict your practice or do a lot of TMD, TMD in particular is something that I don't think should be for the lack of a better word, dabbled in, because you build up, when you start talking about psychosocial history and stuff like that, you build up experience in how to do it. So I think treating TMD needs clinical experience. Like, you can learn the theory and there are lots of papers and things that you can do, but actually seeing patients, learning how to talk to them, that is a very, very huge component. I'm obviously biased, but I think an oral medicine degree will give you the clinical experience in seeing TMD patients. There are a few things online that you can do, or like things through certain universities, like diplomas and stuff like that, that you can do, and I think they're a good start. But I think what I find is that once you start delving into this area, like the Dunning-Kruger effect, like once you once you start looking into a subject, the more you realize that you don't know. So with TMD, I've spent quite a lot of time doing TMD, but I feel like there's still a lot that I don't know. So I think for a general dentist, it is perfectly reasonable to attend courses, short courses, weekend courses, and things like that, to see if that's something that you're interested in doing. But I think to actually make a career out of it, you would need to do it a lot more. So the clinical experience, working in chronic pain departments, shadowing specialists and things like that are all things that I think will give you a fairly good indication as to whether that's something. Because just to give you an idea, fibromyalgia, people with chronic muscle pain. So I had a really good consultant who told me that if I'm seeing a temporomandibular joint patient with fibromyalgia, they don't have temporomandibular joint disorder, they have fibromyalgia, because it's a chronic pain condition that affects the whole body, the multiple pain comorbidities. We work very closely with the psychologist and the psychiatrist. So I think when it comes to TMD, it's quite the experience really makes the difference. So seeing those patients basically is what I'm saying.
Having that continuous exposure to it, to then be able to differentiate and diagnose that you're saying that would help a lot more.
Exactly. The other thing as well, I don't want to draw fire for this because I'm on social media a lot, but with social media posts, especially with something like TMD and a lot of the more hotter or more controversial topics, no matter who's posting it, so even the post that I post, always look at everything with a grain of salt and do your own research. So if you're not sure if something is accurate or not, definitely look more into it if you're about to incorporate some of those philosophies, for example, with your patient. I think the other thing is to actually understand what is accepted practice and what isn't. So I don't have a problem if people deviate from accepted practices, because I know many good clinicians who have developed things over time themselves, and they've got expert opinion and they are deviating from what is commonly done. That's how some of the best clinicians in the world practice, but they know what is accepted practice in the first place. So they are ethical, and they know that if something goes wrong, they are able to defend it. So if you take a Facebook post that asks you to adjust or to do a full mouth rehab and the patient's TMD will go away, or to put a really expensive device that costs $8,000 and the TMD will go away, you just better be sure that you can defend it in front of APRA.
Fair enough.
Pretty much.
You mentioned the psychological component is a really big part of TMD. As we know, the psychology plays a big role in pain and
Yes.
perception of pain in general.
Yes.
Are you often starting with the psychological component when someone comes in with TMD? Is that something you want to tick off first, or is it all interwoven and it's all part of the process at the same time?
Yeah. So yeah, it does. So if you want to see a temporomandibular disorder patient, there is actually the diagnostic criteria for TMD. So the DCTMD, the reference to that is Schiffman 2014. You can actually look it up. It's freely accessible.
Yeah.
They have Axis 1 and Axis 2 things that you need to look up, and that actually helps you manage the TMD patients. Okay. So what that basically combines is both the physical findings, so like things like, jaw deviation, deflection, opening, all of that sort of stuff, and then the anxiety, depression, and the psychosocial. So it comes hand in hand. You cannot treat TMD without looking at psychosocial. So you must do both. Yeah. As to whether you do one first and then the second, I think that's up to you. But as long as you do both equally and give equal weighting to both axes, that's in my opinion, correct way to treat TMD.
Yeah. Oh, no.
So yeah. So to give you an example, when they come in to see me, yep, they have massive questionnaires that they need to fill out. That includes everything from psychosocial to physical to comorbidities, family history, workplace claims, all of that sort of stuff. So yep, we give them the paperwork to fill out beforehand, so they can either fill it out before they come in or they can fill it in at the practice. And yep, that's really a practical thing, because these forms do take a little bit of time to go to do it. And then I sit down with the patients. I find out why they're here, the history of the presenting complaint, what treatment they've tried. I get their social history as well during that conversation. Okay. And then after that, I bring them into the adjacent room and sit them in the chair, and then I do my physical TMD examination. Yeah. So I spend equal time with both. For me, just practically, I do the psychosocial one first, but it's during the same appointment anyway.
Yeah. It sounds very thorough and comprehensive, and I guess it has to be given how broad TMD is and how deep you can really go into all the facets of it. Do you honestly think it's one of the hardest parts of oral medicine?
I think it definitely is challenging, which is also why I think it's rewarding, because when you help these patients, you get a feeling of satisfaction, because these are patients that are really suffering. I think it is not easy, but I think anytime you're talking about chronic pain conditions and psychosocial things, it is never easy, because naturally during dental school, we're not really trained to start asking about this. So for example, there's been a study in the Netherlands, I think, that showed that about 50% of TMD patients have a history of physical or sexual abuse. Like most general dentists won't be trained in asking those things, or they won't be very comfortable asking those things. history of suicide, anxiety, depression, death in the family, like all of these things are things that we have to ask about and acknowledge. Workplace harassment, all of that sort of stuff. So I think from that aspect, it's difficult, because communication is always a challenge. Yeah. And the other part as well that makes it difficult when you're treating chronic pain patients is that the definition, or not the definition, but when you look at success rates for treating people in chronic pain, a 50% reduction in pain is considered as success. So you have to manage the patient's expectations. So it's not something that is easily fixed. For some pain conditions, there is no treatment. All you can do is make them a little bit more comfortable, and it can be difficult sometimes for patients to accept. So I think the psychological management, managing the expectations, and the poor prognosis of chronic pain conditions makes it inherently trickier to treat, but it can be very satisfying when you help these patients.
Yeah, no, I can imagine that would be incredibly rewarding for, someone's been in pain for, 10 plus years, and then finally being able to, even if you don't eliminate it, I feel to be able to decrease that would definitely increase their quality of life.
Yes. And sometimes it's also knowing when to tell the patients that you can't help them anymore, when to do an appropriate referral to a psychologist or psychiatrist. That can also be difficult, because what sometimes happens if you don't get the message right, or you don't educate the patient properly, is that they think that you've dismissed them because the pain is all in their head. And then it's like, of course their pain is in their head, because all pain's in the head, isn't it?
Yes.
Yeah. So it's more like explaining to the patient. So so you do go on a bit of a journey with these patients.
Yeah, no, definitely sounds like it. Well, it's really great to see how passionate you are about it as well. I'm sure your patients appreciate that too. Look, you're also really passionate about teaching and mentoring and sharing on, like you said before, social media.
Yeah.
If anyone listening or watching hasn't checked out, it's at Oral Medicine Oral Pathology. That's on Instagram, and again the website oralmedicineoralpathology.com. Have you always been passionate about teaching, mentoring, and public speaking? Is that was
Actually, not really. I think one of the things about how you end up where you are sometimes is a bit of serendipity, isn't it? As I say, going through dental school, I kind of never really thought about any of this. I've always been on social media ever since I was like 12. You know, I had like a blog spot when I was in high school and all of that sort of stuff. I think it's the media of our generation, to be honest. Like a lot of people around my age are on social media, whether they use it a lot or not. I just found social media very rewarding because I get to meet people that I've never met before. So for example, for you, because we've met through social media, and other oral medicine specialists overseas and interstate with case discussions and things like that. And the other thing that keeps me going is that I people have told me that they found my content useful.
Yeah.
So I think just being able to put the message out there and making oral medicine accessible, I think has been very rewarding. So I guess that's why I keep doing it. So I think it started off as I was already quite familiar with social media, and then when I was doing my oral medicine training, I liked oral medicine a lot, so I started to talk about it and started to post about it, and then it just kind of evolved with doing more and more content.
Yeah, no, look, it definitely really did evolve. And I know we were talking about before how oral medicine is taught really as a really dry subject in university, but definitely the way you've presented it is very engaging. And you actually do get a lot of response from the audience on social media, whether it be a case you've shared on Facebook or posts that you make on Instagram, and the interaction that you have with the audience. It's almost like, in many ways, like a virtual classroom. I don't know if you intend it to be like that, but the way the discussion flows, I think is really interesting, and it's definitely a positive that comes out of social media. You know, that accessibility that you were talking about. Do you find though that there are any negatives or pitfalls with sharing on social media? Have you found?
Oh, definitely. I mean, first off, I must say that I love all of the people that teach oral medicine at the different universities. So this is not intended as a slight. I think sometimes with oral medicine, when you learn it through a university, the focus is just different. Like you're not like it's for exams, it's for recognition, it's for dentists to be safe. I have the luxury of doing it on social media where I don't have to have those same goals, and I can just make oral medicine like oh, look at this interesting case that I saw today. So so no slight intended.
Yeah, no, of course.
Of course, there are social media pitfalls. I mean, going through my training, I've had multiple people tell me that I should be more professional, not spend so much time online. Where do I have time to actually study and do my work if I'm on so you do get naysayers. Like you do get people who generally, I would suspect that they are people who are not as familiar with social media. So they see it as a very frivolous sort of thing, maybe a bit unprofessional. I think once they come round to it, they understand that social media is outreach. Yeah. Is talking to people and giving access to things that people wouldn't normally do it. I mean, of course, teaching oral medicine in a classroom or in a lecture setting, you can go a lot more in depth.
Yeah.
But this is also a medium that's worth considering. So I think earlier on in my career, less now because I guess they don't say it to my face anymore. I was sort of told like maybe I should not be on social media so much. So I think that was a little bit what's the word for it? It wasn't upsetting, but I suppose it was a bit disheartening that I felt that maybe these two worlds couldn't meet. The other thing as well on social media is that I sometimes feel that it may give people the impression that oral medicine can be solved with a photograph. So I get some people that send me photos and they go like, what is this? Yeah. And it's just a photograph. And I'm like, well, what, you got to give me age, medical history, characteristics, lesion history, all of that sort of stuff. So that's that. But that's usually quite easily fixed because I just tell them that they need to have more information or refer them to appropriate specialists. Because at the end of the day, nothing beats a clinical examination. Yeah. And the other thing with social media is that I think the younger generation are actually better at it, but I remember when it first became big, there was a lot of comparison where people would be like, oh, look at all these things that the other dentists are doing. Why am I not doing it? What is this big secret that I'm missing out on? Like, should I be taking CBCTs for patients with sleep conditions? I don't do that. And now, why wasn't I taught that in university? I think people are starting now to realize that maybe a lot of these are opinions.
Yeah.
So I think just making sure that when you look at something at social media, you are not following it 100%. So I think someone said this, I think, was it Tony Rotano? I don't know. Someone has said it quite well, where they basically said that social media is inspiration, but it's not what you should do. So yeah, so it's a little bit like, being quite judicious in what you end up taking away from social media.
Yeah, definitely. I think that's really, really important, because oftentimes we're looking at a single photo, but we don't realize that the person behind that photo has probably had 20 plus years of experience. And that's why they can, for example, in the world of restorations, create something that looks so incredible. Whereas, someone a couple of years out, we can look at that and be like, how can we kind of get to that level kind of thing?
Yes. So I think it's nice to like look at those things and go, wow, that's really great. Like, how can I improve what I'm doing to get to that stage, but not like beat yourself up about it as well, because it's a process. Like, I'm sure, in a similar sense, like I look at the kids nowadays and I'm like, I'm glad I didn't have, I'm glad Facebook wasn't what it was when I was 12, because all the things that I would have put up would have been so embarrassing, all the mistakes that I made. So it's like similar dentistry. Right?
True. On social media, do you have any other big plans for your oral medicine content on either your website or Instagram, or videos you're going to be making? Any plans moving forward?
Not really. So the way that I've approached my social media is that I've kind of just done it as I felt like it, because for me, it's not, it's not a career. It's not. I don't make any money from it. Like, I don't accept any sponsorships and stuff like that. So it's things that I find interesting. So it could be like, maybe one day I see a patient and she's been to multiple people and was given antibiotics for squamous cell carcinoma. So I'll think about it and I'm like, what is the message here that I would like to get out? And then I'll make a post and I'll be like, like, if you see something, review in 2 weeks. Like, it's a way for me to get these messages out. Some things I just find interesting. Sometimes it's if I'm giving a talk or something like that, then I can put it on there and tell people that this is what I'm doing. In my own personal one as well. Like, I make a lot of funny, like, silly videos as well, which I put up on my social. So I don't take myself too seriously there.
You got to keep it fun as well.
It is. So honestly, it is quite ad hoc. Like, I don't have a posting schedule or anything. I just put things on. I think at the moment, because I've got YouTube, Instagram, Facebook, and Twitter, that's probably all I will have at the moment. I like my podcast, because the podcast is actually different from oral medicine. It's just talking to people that I find interesting, or I think that they have a message as well. So I might keep going with that. But at the end of the day, this is sort of a hobby, I suppose. So I devote as much time as I can to it without taking away from my actual work.
Yeah, because I'm sure your actual work obviously keeps you really busy anyway, as it is.
Yeah, a little bit.
Look, just as we finish up, Amanda, for anyone that's listening, that's whether they've been practicing dentistry for only a year or whether it's been 10, 20 years and they're considering oral medicine as a pathway, what kind of advice would you give to them in terms of the journey they have ahead before them and things they should start wrapping their heads around as they kind of progress towards pursuing oral medicine?
Yeah. So I'm actually a very practical person. So a lot of my advice is very practical. Save up as much as you can. Specialty training will take a toll on your finances, no matter what you do. Be really sure that the career that you think oral medicine is actually what you think it is. So that will entail spending time with specialists, spending time around in hospital departments. So making sure that that it is what you think it is. The other thing about specialty, about being a specialist, which a lot of people don't realize, is that there are things that you have to be aware about, which is that there is a lot of networking, building up your referral base, a lot of paperwork, spending time doing all of these sort of things. So you might love maybe oral medicine is bad. Like, for example, okay, let's say oral medicine. So you may love oral medicine, but you also have to love it enough to do only that for the rest of your life. Because the thing is that the reality is, as a general dentist, there is no limitation to your scope of practice. So if you did want to do some oral medicine and you weren't sure, like you can still do that as a general dentist. So I think it's just weighing up why you want to do oral medicine and the restrictions that it will have on your, your social life and things like that. Because a lot of people think that specialty training is the hardest part. You're actually infinitely busier once you come through as well. So I suppose it's it's balancing all of that. But the biggest one is spend as much time in oral medicine as you can, shadowing people, doing courses. Definitely speak to the current registrars in the program, because even though oral medicine is oral medicine, the different universities will have different strengths and weaknesses in training. So you want to tailor that towards your specific interest as well.
Yeah, fantastic. Yeah, definitely good advice to kind of suss out all elements of all courses, before committing to something that you said is quite financially taxing, but also time in terms of time as well.
Yes. Oh, and the other thing as well, for all specialists, not just oral medicine, don't be so focused on getting into the course that you don't think about what happens after you finish the course. So we know that there are some specialties in some states that are absolutely saturated and it's very difficult to find a job. You don't want to invest all the time and money in training to be a specialist and say you've got roots down in a specific place and you cannot move, and then you cannot get as good a job as you thought it was. So that's quite important as well, because it's pyramid, right? So specialists depend on patient numbers as well. So if there are too many specialists in one area, you should be aware of that before you start, because then maybe you will start thinking about moving into a different place or a different state. So I think that's something that sometimes people don't realize, and then they finish and they're like, oh, I can't get a job in this state, I'm going to have to move. So that's probably something that you want to know beforehand.
That's really, really important, especially if you're committing so much time to it as well. Amanda, thank you so much for joining us today. It's been a really enlightening conversation, especially around, I guess, communicating those difficult conversations with patients surrounding, ambiguous lesions and all those things. So if you haven't followed Amanda at Oral Medicine, Oral Pathology, please do so. There's a lot of great clinical tips and tricks that she shares, and sometimes funny content as well, which is always good. And also website oralmedicineoralpathology.com, and the podcast A Spoonful of Oral Medicine. Amanda, thank you so much again for joining us. It was great having you.
Thank you for having me.
My pleasure. See you.